Sandra Ganesh, who's a medical consultant, pediatric ophthalmology and adult strabismus services from Arvind Eye Care Systems based at Coimbatore. And she's going to be talking on managing double trouble, a comprehensive guide to diplopia management.
Thank you very much, Chitra ma'am, for the kind invitation. Yes. So I'll be trying to cover the salient aspects of diplopia management in the next 6 minutes if possible.
It has to be.
Yes.
We'll switch off the mic.
Just give me a minute for the presentation is still loading.
Yeah.
Thank you. And it has to be comprehensive. So deciphering so diplopia is just a perception of two images of a single object, and it has many potential causes which include both strabismological and neurological etiologies, and it's a very huge differential diagnosis. So, but accurate diagnosis and management can be achieved with a good history and a careful clinical examination, and it can be uniocular, binocular or physiological. And initially, I think it's very important to see if the patient is using the term double vision correctly, because sometimes they can confuse a blurred vision with a double vision. So one of the key questions would be to see if the diplopia is present even on the monocular lid closure. So this would be the first thing to test, and if yes, then the patient can have monocular diplopia, where there can be more than two images, polyopia as it's called, where one of the image is usually of normal quality and the rest are of inferior quality. So varying reasons of monocular diplopia, few including refractive errors, uncorrected dry eye, corneal disease, iris injury, cataract, media opacities, and even primary visual cortex disorders, where there can be bilateral monocular diplopia. So here the pinhole test would be one of the easier tests to start with, where you can use a single or a multiple pinhole technique, and if it improves with the pinhole, then the disease is probably a refractive of etiology, whereas macular disease is the same or it is usually worsening, and the nerve disease again remains the same with or without a pinhole. So this is just a brief recap, where with the pinhole, if it improves, then it is refractive error. If it is the same or worse, macular disease, whereas sometimes it can be irregular astigmatism, where you have to do further testing on, and Amsler grid can also be useful. Coming to binocular diplopia, where the eyes lose their simultaneous alignment in different directions of gaze. Varying etiologies include cranial nerve pathologies, mechanical restriction, and neuromuscular transmission disorders. We should also remember intermittent or transient diplopia, which could be decompensated phorias, convergence or divergence insufficiencies, myasthenia, spasm of accommodation, and very rare causes like TIA, superior oblique myokymia, and even cyclic esotropias. Even after ocular surgery, you can have diplopia, like following cataract surgery, where it can be a decompensated pre-existing strabismus, or it could be iatrogenic causes like injection of local anesthetic into inferior rectus or injury to superior rectus, or post-operatively due to a lens tilt or a decentration. And post-refractive surgery, there can be problems with regard to binocular vision anomalies like intermittent strabismus or accommodation issues, and sometimes technical issues in the surgery as such. Post-retinal surgery, again, there are various reasons for causing diplopia, including the buckles, which are rarely used nowadays, damage to recti and by the traction sutures, breakdown of pre-existing fusion. With regard to retinal diplopia, usually if there is some like a macular drag and all, it's very difficult to treat it. So the points in history would be onset, progression, whether it's constant or intermittent, at what time of the day it is occurring, whether it's horizontal, vertical, oblique or diagonal, distance or near, variability with the head posture or with the gaze, any previous episodes, or whether it is with pain. Very rarely diplopia can be due to potentially life-threatening causes. In one study it was around 16% of the diplopia-related emergency departmental visits. So we have to rule out the rare causes also, and review of the other neurological systems with a thorough history taking, and diabetes, hypertension, recent trauma, Graves' disease, multiple sclerosis, and any other drugs. Look at the old photographs to see if the head posture is long-standing or of recent onset. And predominantly, if there is a face turn, it could be because of horizontal recti. Predominantly, if there is a chin elevation or depression, it's vertical recti. And if there is a tilt, it could be because of the obliques. And coming to evaluation, I think Dr. Guha has touched on to it also. And you need to look at deductions, versions, sensory testing prior to the motor testing, saccadic velocity, diplopia and Hess charting, neuroimaging, including an MRA or a CT angiography. The red flags to remember include evolving, younger patient, multiple cranial nerves, pupil involvement and disc edema definitely warrants a neuroimaging. Single fiber EMG is more reliable with regard to myasthenia, and orbital imaging or a thyroid function test. So diplopia and Hess charting has already been detailed. So binocular diplopia examinations, just again just a brief recap. With the cover test, if there is a phoria, it could be causes like decompensating phoria, physiological diplopia, or entropia. If there is, then we need to look at whether it's a horizontal or a vertical cyclovertical muscles. And if the ductions are abnormal, you will proceed with the forced duction testing, as has been detailed again. So the main treatment objective also is to of diplopia is to create the largest and most central area of the single binocular vision with whatever modalities of occlusion or prisms. If there is in fairly committed deviations, we can try prisms, and orthoptic training, Botox or surgery. So thank you.
Thank you, Dr. Sandra, for covering this beautifully with extensive information. One of the key problems we faced with children coming with diplopia or sometimes not recognizing it so much is the acute comitant esotropia that we've been seeing post-COVID. So in the panel, Dr. Vinita or anyone, what is your approach for a child who presents with a possible suspicion of acute comitant esotropia, especially in these last few months to a year?
The thing is, when the child, especially in the post-COVID period, they have been using the computers and the
Mic
computers.
check kar den.
Talk like that.
Yeah, sure, go ahead anyway.
Yeah. So when the children are coming these days in the post-COVID era, obviously it's a computer-based syndrome and the refractive errors have gone unnoticed. So the first thing I would proceed is with the refraction. Depending on the age of the child, a cycloplegic refraction is the first thing which I would be doing for those children. And accordingly, obviously whatever is the cycloplegic refraction findings, if it's going for a hyperopic refraction, I'll prescribe accordingly and give them the relaxation of the complete accommodation of theirs for that acute comitant esotropia to resolve. So that's the first approach would be there. And accordingly, after prescription of the glasses, I'll see whether it resolves it that or not. And in case if it's required for short periods, I may need to even give them binocular, bifocal glasses may also be required for some cases for short periods, or maybe atopenization for the relief of that acute comitant phase.
Is there a role for these mini surgeries in paralytic strabismus? Dr. Pradeep.
So if there are, the person is complaining of diplopia, in such cases which are small angle deviations, you have raised a very nice question. These may require mini surgeries or adjustable surgeries. That is one thing. Secondly, I would like to say, if there is a history of head trauma or a long-standing deviation, you need to pre-check with the correction that the diplopia is getting rectified or not. They may have a cortical fusion disruption, which will never get corrected, and he will always keep on bothering you. So try to see that cortical fusion disruption is also ruled out in long-standing.